All right. Well, that's loud. How's everyone doing? Good? Yeah? You guys are almost done. It's only one more exam left and you'll be done with the class, right? Woohoo. So I just want to remind you guys that this will be streamed online, and there'll be a YouTube video when we're done. During this session, we'll just be going over the study guide that was on the Google site. There will be a session tomorrow from 12 to 2 that Shabana will be doing. She'll be doing a practice test, so I think that complements what we're doing, so you can test your knowledge tomorrow. So try to go to that session if you can. But yeah, and everyone has the study guide? Yeah? Okay. Oh, and in front of you there should be a sheet that you can do a review of this session. And if you just put the number 57 at the top of that paper, that'd be great. And just give it to me by the end of the session, or at the end of the session. All right, so let's get started. So endocrine system, receptors. So what's another name for cell surface receptors? Membrane receptors, awesome. So what type of hormones bind to cell surface receptors? Protein. There's 4 types of cell surface receptors. So one type is G protein coupled receptor. So it has which receptors, which subunits? Alpha, beta, and gamma. And it uses what in the cytoplasm? Carboxyl terminal. So what are these second messengers for the G protein coupled receptors? Do you remember any from, you have some from exam 2, remember? Adenylate cyclase, phospholipase C. What comes after phospholipase C? IP3, awesome. Cool. So these are the main effectors for G protein coupled receptors. So the hormones that use these receptors are prostaglandin, catecholamines, ACTH, glucagon, PTH, and TSH. What are catecholamines again? Which 2 hormones? Epinephrine and norepinephrine. Thank you. Oh, I'm so afraid of burping in this. Sorry. So remember that these hormones bind to specifically G protein coupled receptors. She might have a question where she asks you, which of the following binds to a G protein coupled receptor? And she'll have a bunch of other hormones and one of these. So definitely know which hormones go with which receptors. The second thing you should know, I put a star next to each thing. The second thing you should know is what kind of domain. So in this case, it's carboxyl. And then, yeah, so those are the 2 main ones if you learn any of them, which hopefully you learn all of them. Okay, and then intracellular energy. What's that? CAMP. Awesome. Is this making sense to everyone? Yeah? Okay, cool. All right, so now we have growth factor receptor. So it has a what terminal domain? Amino, right? And the second messenger is tyrosine kinase. The hormones are insulin, IGF, and EGF. So these hormones specifically bind to growth factor receptors. And these are all protein hormones. Growth hormone does not bind to growth factor. This is like the biggest mistake with these questions. Like, make sure you do not think growth hormone when you think growth factor receptor. Okay, so cytokine receptors are specific for growth hormone. And the second messenger, does anyone remember what that is? Awesome, JAK2. And that has tyrosine kinase activity. So again, these are the main two things you should know. What is the second messenger? What is the hormone that binds to it? Sorry, it's like crowded up here. Okay. And the fourth type of receptor for the endocrine system is ligand-regulated transporter, which is also called guanylyl cyclase. She may give either name of the receptor, so know both, guanylyl cyclase and ligand-regulated. This causes an increase in what type of intracellular energy? See GMP. And the hormones involved are nitric oxide, awesome, and atrial natriuretic peptide. And those are all the protein receptors and the protein hormones you have to know for this test. I know she kind of went through this really fast in class, so definitely just go through those 4 or 5 PowerPoints that she did on this. Okay? Cool. So then we're at nuclear receptors. So which type of hormones bind to the nuclear receptors? Steroids. Did I have that? Okay. Yeah, so which type of hormones are involved with steroid hormones? What? Okay, so cholesterol is a precursor. Awesome. That's a great point. So there's sex hormones. What are those? Testosterone, estrogen. What's the other female one? Progesterone, awesome. What about adrenal cortex hormones? What are those? Awesome, so that's one, androgen, cortisol, aldosterone, awesome. There's one other type of steroid hormone. What's that? Thyroid, awesome, T3, T4. And that has a different precursor. What's the precursor for T3, T4? Iodide, right? Iodide. Okay, so T3, T4 are, this is an important distinction. So T3, T4 are nuclear receptors and they're steroid hormones, but TSH is a protein. It's a protein hormone. So don't mix those two up. T3, T4 is steroid, TSH is protein. So when TSH binds to the thyroid gland, it's binding to a cell surface receptor. And then when T3, T4 come out of the thyroid gland and bind to like the heart and all the other locations, that's when it binds inside of the cell. Does that make sense? Yeah? Okay, so we can move on. Actually, real quick, I forgot to mention. So protein hormones, are these faster or slower than steroid? So they're faster than steroid. Are they lipophobic or lipophilic? They're lipophobic. What else is the difference between them? Where do steroid hormones bind? So steroid binds inside of the cell on the nucleus, because they're nuclear receptors, right? So when T3, T4 goes into the cell, it doesn't stop in the cell membrane. It keeps going and affects DNA directly. All right. So now we're at hormones, generally speaking, classifications. So endocrine hormone is a hormone that is released into the bloodstream. Awesome. Bloodstream. While exocrine hormones are hormones that are released into a duct or into a gland. What's an example of that? Yeah, like salivary gland, sweat, etc. Well, paracrine hormone is the first hormone controls secretion of second hormone. So the example is somatostatin suppresses both insulin and glucagon. On a side note, what else does somatostatin suppress? Awesome, growth hormone. And autocrine intracrine binds to its own receptor and controls its own function. Do you know an example of that? Awesome, insulin and also somatostatin. So these types of questions, it'll be one of those easy questions where she asks, like, which of the following is an example of a paracrine hormone or of an autocrine hormone? So it won't be one of those, like, 50-year-old man walks into, I don't know, into a car. Okay, cool. So effects that occur between hormones. So there's synergistic, permissive, and antagonistic. So synergistic occurs when two hormones work together. They're friends to achieve a particular result. So what is an example of that? You guys think of any? Awesome. Epinephrine and what? And norepinephrine. So let's say in the heart, what do they work together to accomplish? To increase the heart rate. Can you guys still see? Sorry. Heart to increase heart rate. All right. So then there's permissive effects. That's when one hormone enhances, the activity or strength of another hormone. So an example is cortisol and catecholamines. So how does cortisol enhance the effect of catecholamines? What does it increase? Increases certain kinds of pressures. Do you remember? Awesome. Systolic and diastolic pressures. And that leads to catecholamines, norepinephrine, and epinephrine to be more effective. Cool. Then we have antagonistic effects. So that's effects of one hormone decreases. I was going to say antagonizes, but using the same word in the definition isn't very good. So the example is insulin and glucagon. Since they react at different times, we're going to talk about each one, but since they react at different, like insulin reacts when, or is active when what? Glucose is high, right? Well, glucagon is active when? Glucose is what? Awesome. So the way I separated the study guide, like this point on, I just did it by organ. So we're going to go like from the hypothalamus to the anterior lobe to the adrenal cortex, and that's kind of how I did it. If you understand it a different way, then study a different way, but that's kind of how I think of this test. So first is the hypothalamus. So the biggest thing that you need to know is that if you see RH in the hormone name, it's from the hypothalamus, no matter what. So if she asks you a question, which of the following is released from the hypothalamus, or isn't it released from the hypothalamus, you pick the one that doesn't end in RH, if it doesn't belong in the hypothalamus. Okay. Is that clear to everyone? Yeah? What about SH? Where is that released from? Anterior lobe of the pituitary. So these are just easy ways of just seeing the hormone and knowing where it's from. And that's the biggest thing on this test. You need to know where each hormone belongs. Because you'll get tripped up. So okay, so it's a main center for which system? Endocrine. It controls sleep, appetite, what else? Memory. Learning. Can you think of body temperature? Yeah. Sympathetic and parasympathetic, your favorite systems. It's a weird noise. Anyway, so now we have releasing hormones. So the names always end in RH. So it travels down which vessel? Do you remember the name of it? Hypothalamic, pituitary, pituitary portal vessel to stimulate anterior pituitary trophic cells that secrete stimulating hormones in the anterior pituitary. So yeah, she always draws that picture, right? So you have the hypothalamus, and then the anterior pituitary and posterior pituitary. So releasing hormones go through this tract, this hypothalamal pituitary portal vessel, to activate the hormones in the anterior pituitary. How does the hypothalamus release hormones into the posterior pituitary? What does it use? Axon, right? Forgot to put that in the guide, but yeah, it's axon. And do you remember which hormones are activated in the hypothalamus that go to the posterior pituitary? One is with oxytocin and ADH. And if anything isn't clear, you can always, I'm going to leave 15 minutes at the end, and you can just ask questions or whatever. All right. Is everyone good with this picture, if that's useful to you? Yeah? Just raise your hand if you're not. I'll keep going. So releasing hormones are secreted. So what does GnRH stand for? Gonadotropin releasing hormone. So it stimulates the release of which two hormones in the anterior and posterior lobe? Awesome. FSH and LH. So now we're at thyroid stimulating hormone, or TRH. On the test, I'm pretty sure she'll just put TRH. She won't say what each thing stands for. So definitely know what it stands for, because it helps you to know what it stimulates. So it stimulates the release of thyroid stimulating hormone, or TSH, and what other hormone in the anterior pituitary? Prolactin. Excuse me. So growth hormone releasing hormone. So what do you think what that stimulates? Growth hormone. It's very redundant. Growth hormone. And then we have corticotropin releasing hormone, or CRH. So that That stimulates the release of what from the anterior pituitary? ACTH. And we'll get to what each one stands for in the next section. And it also stimulates the release of, what does POMC stand for? Do you guys know? Cortin, yeah. So melano, what does that have to do with? MSH, awesome. MSH, and that has to do with pigmentation, right? So what condition did we have where CRH is increased abnormally, causing an abnormal increase in MSH and POMC? Addison's, right? So I'll put Addison's here, but we'll get there, obviously. And what president had that? Kennedy, yeah. And it kind of looks more like freckles than it looks, it's not as bad as you would think it'd be when you think of hyperpigmentation. We looked up pictures in one of the SI sessions, I think. Okay, so it's also endorphins and lipotropins, I think. That one I wasn't sure about because you guys said it in the other class that I don't go to. Did she say lipotropins in the 130 class? Do you remember? Okay, cool. Just making sure. So then there's somatostatin. What does that do with the release of growth hormone? It inhibits, right? Prevents. Okay, and then dopamine, what does that do when it's released in the hypothalamus? So it has something to do with prolactin. Awesome, inhibits the release of prolactin. So if you have a condition like prolactinoma or anything with an abnormal increase in prolactin, how would you treat that? Synthetic dopamine. Did she give you a specific drug? Bromocriptin? Is that it? Bromocriptin? That might be right. I don't think it was for this test that she gave it to you, though. Awesome. So these two hormones are what type of releasing hormones? What? Inhibit, right? So these are inhibitory releasing hormones, and all the other ones before were releasing hormones. So again, for this test, just know that all these hormones are from the hypothalamus. Know what they stimulate in the anterior lobe of the pituitary. And know that these two are inhibitory and the rest are releasing. And again, everything that ends in RH is from the hypothalamus. That's huge. Okay. Can I keep going, or is everyone still writing things down? You good? Yeah? Okay. Cool. So now we're at other hormones produced in the hypothalamus. So one is oxytocin. It's important for pregnant female. It helps with what of the uterus? Contraction. It also dilates the cervix, which is important. It's important for male reproductive life. It contracts smooth muscle, a blood vessel for ejaculation. She didn't say this in class, but in case you're just wondering, it's also considered like the love hormone. And whenever they do studies about love, they always like put people in love in an MRI, and they see like increases in oxytocin, and it's pretty interesting. In case you were wondering. So then the other hormone is ADH, antidiuretic hormone. So it's activated when blood osmolarity is increased. And it stimulates what reabsorption? Water. Awesome. Okay, so both hormones are produced in the which nuclei? Supraoptic and paraventricular nuclei of the hypothalamus. And both are stored in which lobe of the pituitary gland? Posterior. Awesome. So that was all the hypothalamus. So now we're at the next organ, which is anterior pituitary hormones. So there's this really cool acronym, flat pig, which is a weird thing to visualize. But that's how you'll remember all the hormones that are released from the anterior pituitary. If you remember that acronym, you'll be good for the test. So the first one is F, which is follicular stimulating hormone, or FSH. It's released from the anterior pituitary, if you remember, by GnRH, gonadotropin releasing hormone. So males, what does FSH do in males? Maturation of sperm. The way I remember that is FSH sounds like fish, and sperm look like fish, so that's how I remember it. I don't know if that helps, but that's one way to remember it. So with females, it increases during which 2 weeks of the menstrual cycle? The first 2 weeks. It controls development and maturation of the follicle. So this is when the follicle is growing, filling up with blood. The ovary is still in the follicle, and FSH just stimulates that growth. So now we're at luteinizing hormone. That's the L in flat pig. It's released from the anterior pituitary by GnRH. In males, it controls secretion of what? Testosterone. From which type of cells? Leydig. Yeah. So for females, it increases during which 2 weeks of menstrual cycle? Last 2 weeks. The receptor in the ovary for LH causes rupture of the follicle and elimination of what from the follicle? Ovum. To travel towards the fallopian tube. It also controls what? Ovulation. Awesome. Which are days 13, 14, 15. So real quick, when the ovum is released, where does it go? Fallopian tube. Awesome. Always be visualizing where everything is going. So now we're at ACTH, or adrenocorticotropic hormone. So right away, you should see CORT of adrenocortico and think adreno and think adrenal cortex. So if it's affecting the adrenal cortex, which hormones are being stimulated? Cortisol. What else? Aldosterone. Androgen. I think you guys learned about this like a million times. All about the cortisol. It's stimulated by the release of what in the hypothalamus? CRH, right? Cortical releasing hormone. So again, it goes CRH, ACTH, and then cortisol, aldosterone, androgen. So now we have thyroid stimulating hormone. Stimulates the release of T3, T4 in the thyroid gland. Stimulated by the release of what in the hypothalamus? TRH. Thyroid releasing hormone. So now we have prolactin. That's stimulated by the release of what in the hypothalamus? TRH, right? Definitely remember this, because if you remember that thyroid hormones and prolactin are somehow related, it'll help with the clinical cases that we'll eventually get to, hopefully. Okay, cool. So prolactin controls mammary gland for what in female? Breastfeeding. What does it do to sex hormones in pregnancy? It inhibits. And it's inhibited by what from the hypothalamus? Dopamine. Cool. All right, so now we're at growth hormone, stimulated by the release of what from the hypothalamus? The really redundant one. Growth hormone, releasing hormone. So levels highest during pregnancy and childhood. Which makes sense, right? That's when you grow the most. You grow into a person during pregnancy, you grow into an adult during childhood. So during pregnancy, it is secreted by the placenta. Awesome. That's important for cell growth and proliferation. Just normally. So for pathological conditions, what is a deficiency of growth hormone called? Dwarfism. So if a baby is born with dwarfism, how do you treat that patient? What do you give them? Awesome. You treat with synthetic growth hormone. You also have gigantism, which is caused by excess of growth hormone. What can this cause? What is big heart called? Cardiomegaly. If only everything in medicine was just that simple, like big heart and big stomach. But yeah, basically heart, big. Cardiomegaly. So that causes a cardiovascular disorder, and long-term causes what? Heart failure. Just like that one Robin Williams movie. All right, so now we have posterior pituitary hormones. So this is a review. What does it store? Oxytocin and ADH. That's really all you have to know about the posterior pituitary. Okay, so now we're at the intermediate lobe. So we talked about this already, but POMC causes the release of MSH, which can cause hyperpigmentation if irregular. Excuse me. What do endorphins do? Yeah, so it's pain relief. That's why, like, whenever you go to the gym and you feel good, those are endorphins. That's why people keep going back. Hopefully. And then there's lipotropin. So now we have adrenal cortex hormones. So now we're away from the brain, and we're moving on to the next organ down. So what from the brain stimulates adrenal cortex hormones? ACTH, and what's before that? CRH. So it goes CRH from the hypothalamus, ACTH from the anterior lobe, stimulates adrenal cortex hormones. So first we have aldosterone. It's a mineral corticoid from the zona glomerulosa. Know all the zonas, because for some reason it's in your PowerPoint. I mean, it's in there for a reason, so definitely know them. And I have them all here. So let's review the renin, angiotensin, aldosterone. So when is this active? So low blood pressure. So what does renin do? Converts angiotensinogen into angiotensin 1. What's next? How do you get to angiotensin 2? ACE. Awesome. Just like what you're going to do. You're going to ace the test. Yeah, so you have, it's literally angiotensin converting. Oh, yeah, sorry. Not used to this thing. Converting enzyme. Oh, yeah. Wow. Did not think this through. I'm actually going to wait until everyone writes that down, and then I'm going to move it. If that's okay. Give me time to drink. Is everyone good? Yeah? No? Okay, sorry. And again, she might give you just a question about this where it's like, which of the following is the pathway for the renin-angiotensin-aldosterone system? And she'll give you like, renin converts angiotensin into angiotensin 1, and that whole like sentence answer thing that she does. And you'll have to know which one is the correct order. You guys good? Yeah? So angiotensin 2 does two things. What's the first thing that it does just by itself? Vaso what? Constriction, thank you. And then what does it activate? Aldosterone, thank you. And where does the aldosterone go? The kidney. And what is the cause of reabsorption of? Sodium. What else? Water. Okay. Chlorine. And hydrogen. No, not hydrogen, sorry. HCO3. So these things are reabsorbed. So what's excreted into the urine? Potassium and hydrogen ion. Awesome. Is everyone good? Yeah? Okay, awesome. So let us move on. And yet, this session will be recorded, but Shabana's won't. So if someone goes to Shabana's, if you could post it on the Facebook page, because I know some people have finals during that time, like the answers. That'd be great. Okay. So aldosterone increases blood pressure. It increases, and we just did this. So what does it increase the reabsorption of? Sodium, chloride, what else? HCO3 and water. Cool. And what excretion? Potassium and hydrogen. Awesome. Thank you. So the pathological condition is Conn's disease. So remember, if you only see these symptoms that I say, it's Conn's. If you see anything with glycemia, that's like hyperglycemia, it's not Conn's. Because like, as you could see, we didn't do anything with glucose when we talked about aldosterone. I think that was a question that she had in class. And yeah. Cushing's is essentially Conn's disease plus the symptoms of cortisol and androgen excess. So anyway, we're at Conn's. So the symptoms of hypertension. So these are the symptoms she always puts. Do you guys remember what they are? Headache. What else? Nosebleed. What? Vomiting. I should have this memorized. Anything else? Nausea. Is there anything else? Yeah, it could be a sleep problem. Cool. So the big things you'll always see is it hypo or hypernatremia? Hyper. Okay. Okay, should be. Hypokalemia. Are you going to have acidic or basic urine? Acidic. And you're going to have acidic or basic blood? Basic. Not going to make a joke about basic. And then you'll also have a sleep disorder. So again, only these symptoms is Conn's. All right. So now we're at cortisol. Pretty sure it's her favorite hormone. So if you're going to know any hormone, know that one. So cortisol is a glucocorticoid from the zona fasciculata. Increases blood pressure by stimulating which pressures? Systolic and diastolic. And increasing total peripheral resistance. So what else is cortisol responsible for doing? So it regulates, can you guys still see? Okay, regulates blood glucose. What else? Yeah, so we have blood glucose. What does it normally do, though? So it's anti-inflammatory. The one thing that I just started understanding from taking immuno is that inflammation is good. So if you don't have inflammation, what happens? You get sick, right? Yeah. So cortisol can cause, yeah. Anyway, so what else does it do? Okay, so it suppresses immunity. Immunosuppressant. What about appetite? What does it do with appetite? It just regulates, yeah. And what is cortisol called? The what hormone? Yeah, it's the stress hormone. So it might be running through your veins right now. That's why you get sick during finals week. That's why you get really hungry during finals week. It's not very fun. What else does it do in terms of, yeah, what else does it do? Can you guys think of anything else for cortisol? What? So gluconeogenesis, awesome. It's the one I always forget about. What else? Lipolysis. And what does it do with protein? Awesome, degrades it. Is there anything else? Or is that it? That's it? Okay. That's all I have too. So yeah, with all these hormones, if you know what they do, you know what happens if it's in excess or deficiency. What were you going to say? So your question was, because yeah, it's recorded. So your question is, if the differential between cons and Cushing's is that aldosterone is in cons. Cushing's has all the symptoms of aldosterone, androgen, and aldosterone. Cortisol, androgen, and aldosterone. So the differential diagnosis is Cushing's has the symptoms for excess androgen and excess cortisol, as well as aldosterone. Does that make sense? Yeah? Okay. And we'll get to Cushing's in a second, and it will all become clear. Does everyone have this written down? Yeah? Okay, cool. So now we're at androgen. The sex hormone is from what? Zona reticulata. In females, it's responsible for what growth? Hair growth. What's the first sign of puberty for females? Axillary hair, right? Awesome. Cool. So now we're at the pathological condition of the adrenal cortex. So while, I forgot to say this, while Conn's disease is a tumor of specifically the aldosterone secreting cells, or basically the tumor of the fasciculata. Yeah, fasciculata. No. Glomerulosa. Yeah. Anyway. This is the whole adrenal cortex has a tumor for Cushing's. Not just one part. So for primary Cushing's, is it a reduction or excess of hormones? Excess. So the symptoms I'm going to do by hormone. So we have aldosterone. So if you have an excess of aldosterone, we already did this, but let's review. What will you see as in terms of symptoms? You'll see hypokalemia. What else? Hypertension. What else? Hypernatremia. What about urine? Is it going to be acidic or basic? Acidic urine. And basic blood. So you'll have these symptoms for Cushing's. So you're also going to have an excess of cortisol. So an increase in cortisol, if I can try to, I can't get both, whatever. If you see an increase in cortisol, how does that affect your glucose? Do you have hypoglycemia or hyperglycemia? You have hyperglycemia. You have, what else? You have weight gain. What were some specific things she said? Central obesity. Moon face. And you'll have thin appendages. So you'll be really big here and here, but you're going to have really thin arms and legs. So why do you have really thin arms and legs if you have too much cortisol? Awesome. That's due to protein degradation. Oh, I'm getting into feedback. Oh well. What happens with your immune system? Compromised immune system, right? Is there anything else? I think that's about it. So you're going to see these symptoms, and then for a female, you have an excess of androgen. Because with male, it's one drop in ocean, she always says. Like, if we have an excess of androgen, it doesn't really affect our functioning, because we have testosterone. So for a female with an excess of androgen, what are you going to see? So you're going to see hair growth, specifically facial. Infertility, thank you. What about menstrual cycle? Is that going to be happening? No. So I'm just going to put amenorrhea. That just means you're not having a menstrual cycle. So with Cushing's, you're going to see all of these symptoms. Well, cons, it's just these symptoms. Is that making sense? Cool. Because she loves asking like a million questions about cons and Cushing's to make sure you know the difference. So if anyone doesn't understand, definitely let me know at some point. All right, so now we have feedback. So we're talking about primary, right? So where was the tumor in primary Cushing's? Adrenal cortex. So the adrenal cortex has a tumor. So what does it tell your brain to do? If there's an increase in aldosterone, androgen, and cortisol, what does it tell your hypothalamus to do? Awesome. So decrease ACTH and what else? And CRH. So with primary, there's always going to be feedback. With any condition we talk about today, you'll have feedback for primary. You won't have feedback for secondary. And feedback is essentially an organ telling the brain to like fix the problem. So it's basically like if a kid is being overactive, it's like the parent saying, okay, you need to slow down. It's the same kind of concept. So, yeah. So a differential diagnosis between primary and secondary is that primary Cushing's will have a decrease in ACTH and CRH, while secondary will have an increase in CRH and ACTH. And we'll get to that. Does that make sense? Do you need me to explain it a different way? Or you good? Okay. So let's keep going. Oh, okay. So the increase in adrenal cortex hormones tells the hypothalamus and anterior pituitary to do what with CRH? What? Inhibit, yeah, decrease. CRH and what other hormone? ACTH. Great. So now we're at secondary. So secondary, there's an increase or decrease of hormones due to tumor. Increase. So it's the same symptoms as primary. You're not going to see any difference in terms of the symptoms. But the feedback, there is no feedback. So CRH, ACTH, cortisol, androgen, and aldosterone are all what? Increased. With secondary, everything's going to either be increased or decreased, if that's a way you want to remember it. All right, now we're at Addison's disease. It's basically the opposite of Cushing's. So primary, Addison's. So it's increase or decrease in adrenal cortex hormones. Decrease, right? Reduction. Due to tumor, infection, manipulation, or what of the adrenal cortex? destruction or removal. So if you have bad doctor removes the adrenal cortex, that's what will happen. You'll get Addison's. Okay, so symptoms, we're going to do the same thing we did before. So let's do aldosterone. So you have hypernatremia or hyponatremia? Hyponatremia. Excuse me. Because what's happening is, in the kidney, if you don't have that aldosterone to cause a reabsorption of the sodium, it just goes into the urine. So with that same kind of thought, potassium isn't being excreted into the urine. So do you have hypo or hyperkalemia? Hyperkalemia. Awesome. So what about your urine? Do you have acidic or basic urine? Basic urine. And will you have acidic blood or basic blood? Acidic blood. And will you have hyper or hypotension? Hypotension. So all those symptoms like nosebleed and all of those, probably not going to be present with Addison's. So again, this is when aldosterone is low due to a tumor, removal of the adrenal cortex, manipulation of the tissue, anything that decreases the functioning of the adrenal cortex. So now we're at cortisol. So will you see hyper or hypoglycemia? You'll see hypoglycemia. Will you see weight gain or weight loss? You'll see weight loss. What else will you see? So you'll see hypotension. Awesome. Because you're not increasing systolic and diastolic volume. What about your immune system? That should be alterated, yeah. Alterated immune system. I would think it'd be normal too, but it's alterated, yeah. And is there anything else with cortisol in terms of symptoms, you think? There's a decrease in cortisol due to Addison's? Okay. If you remember any, just let me know. And then we have androgen. So if you see a decrease in androgen, again, in a woman, what will you see? Oh, awesome. Good point. So increased inflammation. Cool. Thanks. Yeah? Oh, is there still? For low aldosterone? For low cortisol? Okay. Awesome. I didn't know that. Nausea and vomiting. So again, if you don't have that androgen to start puberty, it starts later on. So that's why you have late puberty. Yeah? You'd have more, but inflammation sometimes stops the virus or bacteria in its tracks. So you'd have like alterated immune system still. Yeah. So anyway, would you have hair growth in a woman with androgen or without androgen? You'd have very low hair growth. I'm not sure if she said this in class, but does it affect menstruation at all? No? Okay. You don't know? Does anyone know? No? Okay. If she didn't focus on it, then it's not that important. Let me know if you find out otherwise. Okay, so now we have feedback for Addison's. Feedback for Addison's is the most important feedback that you need to know for this test. Okay, so the increase or decrease in adrenal cortex hormones. Decrease tells the hypothalamus and adrenal cortex to do what to its secretions? Increase. Remember, primary is opposite. So it increases secretions of CRH and ACTH. Oh yeah, sorry. So this abnormal increase in CRH causes an increase in POMC, pro-opiomelanocortin, and then POMC causes the secretion of MSH, thank you, which causes hyperpigmentation. So hyperpigmentation can be seen in the face, lips, hands, and palmar region. Again, all of these that we've been talking about are tumors. Yeah, we've been really talking about tumors, so most of the time for treatment, you just remove the tumor, if you can, depending on how big it gets. So now we are at secondary Addison's. So is it an increase or decrease of adrenal cortex hormones? Decrease. Remember, Addison's always decrease. Due to tumor, infection, manipulation, or destruction of the what? Hypothalamus or anterior pituitary. Probably the anterior pituitary. If you have the destruction of your hypothalamus, you have bigger problems than Addison's disease. All right. So let's. So this causes a what in CRH and ACTH? Decrease in CRH and ACTH. So the symptoms are the same symptoms except no what? Hyperpigmentation. So why is there no hyperpigmentation? Yeah, so there's no abnormal increase in CRH. So there's no increase in what? POMC. And there's no increase in MSH. So then you have no pigmentation, no hyperpigmentation. Still have pigmentation. What is that noise? Sounds like a dentist's office. Okay, is everyone good? Is this making sense, the difference between Addison's and Cushing's? Yeah? Okay. If you have any questions, you can ask me at the end. All right, now we're at the adrenal medulla. So we have epinephrine. So epinephrine causes a contraction of smooth muscle of what? Blood vessel. Oh, sorry. And controls what metabolism? Glucose. So norepinephrine causes a dilation or relaxation of the sphincter of the smooth muscle, and beta-1 causes an increase or decrease in heart rate. Increase in heart rate. And contractility of the myocardium. So the only pathologic condition of the adrenal medulla that you're studying is pheochromocytoma that you've done like a million times. So it's caused by what of the adrenal medulla? Tumor. Symptoms are hypertension, headache, vomiting, and which cardia? Tachycardia. The treatment is a beta blocker. What is a beta blocker? Propranolol. Remember, like, you don't LOL when you're having a heart attack. That's how you remember. All right. So now we're at T3 and now we're at thyroid gland. So we're away from the adrenal cortex, adrenal medulla, adrenal gland, and now we're at the thyroid gland. So T3 and T4 formation. This is really important. There may be a question on this. So iodide pump causes iodide from the blood, or carries iodide from the blood with sodium. It oxidizes iodide to what? To what? Iodine. Yeah, thanks. Organification is just a process in which iodine and what part of thyroglobin? Tyrosine? Forms monoiodotyrosine, or MIT. So MIT plus MIT is equal to DIT. What plus MIT is equal to T3? DIT. And what plus DIT is T4? DIT. T4 can pass through the what? Placenta. And is then converted into T3. That's really important. Because if thyroid, well, we'll get to that, but if a baby can't get thyroid hormone, it can be really bad for its development. So now we're at T3 and T4 during intrauterine life. So it's important for the development of what gland? Thyroid gland. It's important for the development of the CNS. What's the CNS again? Central nervous system. And what does that contain? The brain, spinal cord. And which growth? Bone growth. So deficiency of maternal T3, T4. So the mom doesn't have T3, T4 to give to the baby. It causes congenital hypothyroidism. And I think we'll get to that, yeah. So the symptoms, what will you see in a baby that doesn't have T3, T4? What? Yeah, so mental disorder. What else? Speech disorder. Speech, memory, learning, yeah. Learning disorder. What about bone? So bone growth disorder. And can you think of anything else? There's also thyroid gland disorder. So the treatment, I think she says, right when the baby is born, you want to give the baby T3, T4, like immediately when the baby's born, if you're a good doctor. Okay, so now we're at T3 and T4 after birth. So after birth, I don't know why I moved it this much, controls body temperature. Does it increase or decrease oxygen consumption? Increases. It controls the body's metabolic rate. It functions in memory and learning. It stimulates what adrenergic receptors? Alpha 1 and beta 1. And real quick, so what do alpha 1 adrenergic receptors do? So constrict blood vessel. And what does beta 1 do? Awesome. Increases contractility, increases conduction velocity of the heart. And know if that's clear. Heart. Regulates sleep, and it does what with glucose absorption, lipolysis, glycogenolysis, gluconeogenesis? Increase or decrease? Increases. So yeah, these are the main things, T3, T4, main things that they do. So there are quite a few pathologic conditions of the thyroid gland. So there's adult hypothyroidism. So there's primary. So what are the symptoms of hypothyroidism? So weight what? Weight gain. If you have a low amount of thyroid, right? Low T3, T4. Always cold, awesome. That's a big one that she always has on the test. It's either like always cold or always hot. That should signify right away hypothyroidism. It's always cold. What? Sorry, can you? Oh, dry hair and skin, okay. Awesome, that's a big one too. What about heart rate? Bradycardia? Tom bradycardia, yeah. What are you, yeah? That's a good question. So what do alpha receptors do other than constrict blood vessel? I'm pretty sure they, yeah, it secretes. I don't think it secretes sebum, but I think it's responsive for moisturizing hair and skin. That was a weird word. So I think that's what does it, alpha 1, yeah. No problem. So you have bradycardia, you have weight gain, always cold. What else do you see? What? Sleep problem, okay. Awesome, so you're always tired. Why are you always tired? Exactly, so you have low oxygen consumption, so all the things that you do with energy is decreased. You're also weak a lot, weakness. I don't, if it regulates, I don't think you would see hyperglycemia for hypothyroidism, yeah. I don't think she ever gives it as a symptom. You can correct me if I'm wrong though, yeah? Awesome, memory. So I'll put that over here, memory. Put a line here too, disorder. Does everyone have this written down? Okay. Didn't really get an answer, but okay. So feedback. So what do you have with hypothyroidism? An increase or decrease in T3, T4? Decrease in T3, T4 causes a what in TSH and TRH? Increase. You're getting the hang of it, guys. I think that's Graves, because that's for autoimmune. This isn't autoimmune. Yeah, but it's okay. We'll get there. keep that for Graves. So how does this relate to prolactin increase? So you have an increase in TRH. What does that do to prolactin? Does it increase or decrease prolactin? So what does an increase in prolactin do? Yeah, so it suppresses FSH and LH. So for males, what would that do? Would you have spermatogenesis? You'd have low testosterone. You would have low spermatogenesis. What about for females? Would you have menstruation? If you don't have FSH or LH? No, right? No menstruation. Cool. So these are the symptoms you'll see if there's an abnormal increase in prolactin, like there is in this condition, in hypothyroidism, primary. You'll also, what other thing happens with prolactin? If you have an abnormal increase, what does it do for a female? Lactation. So actually, if a male or a female gets an increase in prolactin, they'll both menstruate. Not menstruate. Lactate. Sorry, lactate. They'll both lactate. Did not mean to make that mistake. Both lactate. Okay. Yeah. Which either way is scary, right? Anyway, now we're at secondary hypothyroidism. So it's the same symptoms, but there will be a what in TSH and TRH? Decrease, causing a what in T3, T4? Decrease. Remember, everything increases or everything decreases in secondary? Yeah, in this case, decreases, yeah. So now we're at Graves'. I always call it the zombie disease because grave, yeah. I'll explain why as we go through it. So it's based on what? Autoimmune. That overstimulates the TSH receptor. So instead of TSH binding to the thyroid gland, all these antibodies are binding to the thyroid gland of the follicular cell of the, I guess I said thyroid gland. So this causes an increase or decrease in T3, T4. Increase. Awesome. So feedback, the increase in T3, T4, sends feedback to the brain to do what? To decrease TSH and TRH in the anterior pituitary and hypothalamus. Everyone have everything down? Yeah? Okay, I'm going to move on. Okay. So infiltration. So the infiltration of the antibody. So this causes what? Yeah. Oh no, specifically of the antibody. Yeah. What did she say? Like, where does the antibody go? The eye, right? So it goes to the eye and causes what? What? So it could cause blindness, but what it specifically does, it goes retroorbitally, and it causes exophthalmia. So what literally happens is the antibodies go behind your eye and start pushing. So you have bulging eyes. So I'm just going to say big eyes. So if you're a doctor and you see a patient with Graves', you'll be like, why are you so shocked? Or why are your eyes so big? What big eyes you have. Okay, so I'm just going to put big eyes. Awesome. So now we're at the increase in T3, T4. So that causes cardiovascular problem due to what? Overstimulation of what receptor? Beta 1. Causes hypertension due to overstimulation of what receptor? Alpha 1. Causes what in TSH and TRH? if it's primary? Decrease. Is it weight gain or weight loss? Weight loss. Is it dry or wet skin? Or oily? None of the above. And sleep disorder. So, yeah, that's Graves' disease. Graves is usually just primary because if you have antibodies in your brain, you have a bigger problem than Graves because it's just attacking everywhere. So then we just have secondary hyperthyroidism. So it's caused by tumor, adenoma, irritation, or infiltration of what? Anterior pituitary. Causes oversecretion of TSH and TRH. This causes a what in prolactin? Increase in prolactin. And then it's all the symptoms we discussed for hypothyroidism. Primary hypothyroidism. So now we have gestational. It could be hyper or hypothyroidism, and it spontaneously disappears after delivery. So basically, when a woman is pregnant, she looks like she has hyper or hypothyroidism, and then it just goes away. The baby doesn't go away, the thyroidism goes away. So then there's then there's Hashimoto's thyroiditis. So it's literally the inflammation of the thyroid gland. I don't know why I put this, but it could be hypo or hyperthyroidism. And we already know the symptoms of both. So now we're at the parathyroid gland. The parathyroid gland secretes which hormone? Mumble, PTH, yeah. So what does this do to blood calcium? Increases blood calcium. Calcium affects the neuromuscular junction, bone growth, and action potentials. The receptor in the bone removes, so when PTH binds to the bone, it removes calcium from the bone, and it takes it where? Eventually, but it'd be bloodstream. The receptor in the epithelial cell of the small intestine increases or decreases calcium absorption? Increases. The receptor in what tubule of the nephron? Distal. Causes an increase or decrease in calcium absorption, yeah. PTH also converts vitamin D precursor to the active form of vitamin D. What is that called? 1,25 dihydroxycholecalciferol. Say that 5 times fast. Definitely know the name. Definitely know that. Or be able to recognize it. She could put like 135, 155. Yeah. So now we have pathologic condition of the parathyroid gland. So we have hypoparathyroidism. The cause could be due to tumor in parathyroid gland or removal of the parathyroid gland. Remember, if any gland is removed, it causes hyposecretion. So the symptoms, muscle spasms, weakness, osteoporosis. So why is there osteoporosis if you have a low amount of parathyroid hormone? Because it's not removing calcium from bone to send it to the bloodstream, right? Alteration of which nodes in the heart? SA and AV. And it causes what cardia? Birdie. Awesome. Has everyone got that? I moved pretty fast. Everyone good? Okay. So over time, that can cause heart failure. If your heart's beating too slow, the blood won't go throughout the body, and eventually it'll fail. So now we have hyperparathyroidism. The cause is an increase or decrease in PTH. Increase. The symptoms, it removes too much calcium from bone, which causes what? Oh, actually, I lied. Sorry. The osteoporosis. The osteoporosis here is caused by vitamin D not being created. Since the parathyroid hormone is responsible for the conversion into the active form of vitamin D. Does anyone remember what the active form of vitamin D does with calcium? Yeah. So it helps with calcium absorption. So if you don't have that vitamin D, you have a low amount of calcium in the bone, which causes osteoporosis. Is that clear? Sorry, I forgot about that. Yeah. So in this case, if you don't have PTH, you don't have a formation of vitamin D. Vitamin D is what adds calcium to the bone, while PTH removes calcium from the bone. So in this case, if you don't have addition of calcium to the bone, you're going to have weak bone, and that's osteoporosis. So the osteoporosis caused by hypoparathyroidism is due to calcium not being added. And then the osteoporosis caused by hyper is caused by too much removal of calcium from the bone. Does that make sense? Yeah? She never explicitly says it, but that's the mechanism. So I'm going to move on, if that's okay. Okay. So can cause which stone? Kidney stone. Probably other stones, but mainly kidney stone. It causes which cardia? Tachycardia, and it also causes muscle spasms. So now we're at the pancreas, which is the exocrine part. Secretes amylase. What else? Lipase, protease, and bicarbonate. Yeah, forgot about that one. Well, the endocrine part secretes insulin. So which cells secrete insulin? Beta cells. Insulin is sensitive to blood glucose. When blood glucose is more than what? 120, I think she said in class. Yeah? Causes closure of which channels? Potassium. So if you remember from that action potential we always do, potassium causes hyperpolarization, or causes repolarization. So if you're inhibiting repolarization, you're basically prolonging depolarization, which causes depolarization to continue. So which glute is a secretory vessel full of what? Insulin. Outside of the cell through endo or exocytosis? Exo. Insulin binds to the cells in the body and activate GLUT4 for glucose uptake. Don't mix those two up. That's a very easy question on the test if she asks. She can put like GLUT1, GLUT2, GLUT3, GLUT4. Don't miss that question. So now we're at the pathologic conditions. So you can have insulin deficiency. So if you don't have enough insulin, what does that cause in the blood? Hyperglycemia, polyneuropathy. What is that? The brain, neuro. Brain, I don't want to put damage, like brain problems, I don't know. Yeah, Rupture of what? Hmm? The what? Yeah? Oh, okay. So yeah, so glucose can't go into the brain, which causes problems. Because neurons, I think neurons are the things that use glucose the most in the brain. And if glucose can't get into those cells, then there's a huge problem. There's also vasculopathy, blindness, renal artery destruction. If it's over 300, what is it? What urea? So there's glucosuria. There's also polyuria. There's dehydration, and there's ketoacidosis. So it's basically all the arteries are kind of getting damaged. Yeah? I think it's 300, right? Or is it higher than that? 350? What did she say in class? 350, okay. Yeah. That's when you urinate a lot. Like, you just go use the restroom all the time. I think on Scrubs, one of the main characters, spoiler alert, gets diabetes. And as he starts peeing all the time, and he's like, why am I urinating all the time? And then he figures out he has diabetes. So that's a huge differential diagnosis for diabetes. And if you're anything like me, if you start using the restroom all the time for some reason, you'll think that you have diabetes, which is, yeah. That's a real thing, medical school disorder. You think you have every condition that you learn about. Yeah? Yeah, so the glucose, like if there's no insulin to let the glucose into the cell, the glucose just stays in the blood. So it's hyperglycemia. It's literally saying like there's a bunch of glucose in the blood that can't go into the cell. Does that make sense? Yeah? Okay. Cool. So now we're at type 2 diabetes. So what is happening with insulin? It's normal. You have a mutation of the insulin receptors, and you treat with which drug? Metformin, to decrease blood glucose level. You also have gestational diabetes, which spontaneously disappears after delivery. Again, the diabetes disappears, not the baby. And you also have insulinoma, which is a tumor of the which cell? Beta cell, which causes the oversecretion of insulin. Okay, cool. Making good time. So glucagon is secreted by which cells in the pancreas? Alpha cells. No? Yeah, alpha cells. In the pancreas, when glucose level is low. It controls glucose metabolism in liver. We also have somatostatin, released by which cells in the pancreas? Awesome. It acts as a paracrine hormone to suppress insulin and glucagon. Pancreatic polypeptide cells, or PP cells, are less than what percent of pancreatic? You guys just remember those numbers so easily. And it has paracrine effect. So now we're at the pineal gland. It secretes what, which controls sleep? Melatonin. Is activated in darkness. That's why a lot of people have insomnia when they watch a lot of Netflix, because the light from your screen stops you from thinking that it's night. Yeah. When you binge watching Arrow. Precursor is what? Serotonin. And atrophies with age. That's why older people can't get enough sleep, because they don't have enough melatonin that's being secreted. So now we're at progesterone for sex hormones. It's important for what? Pregnancy. What did she say birth control? Like, what are those hormones? Estrogen and progesterone, right? So I'm just going to put birth control. So it increases after fertilization of the ovum. It prepares and maintains what for implantation? Endometrium. Great. Something in progesterone causes spontaneous abortion. Decrease. So if progesterone decreases randomly, that's when you're going to have an abortion. Because the baby can't, or it can't be implanted, so it just gets lost. So now we're at testosterone. During intrauterine life, it controls the descending of the testicle from where? Abdominal cavity to the scrotum. Why does it go to the scrotum? Why doesn't it stay in the abdominal cavity? It's a weird question. Temperature, right? You want to make sure spermatogenesis happens. If there's an abnormal increase in temperature, that can affect it. Also affects development of genital organs. So after puberty, it's responsible for a stronger muscle and libido. Deficiency causes what in a male? Depression. And alterated reproductive life. So that's all endocrine. That'll be a good percentage of your test, maybe 60, 70%. So definitely know everything we talked about and a little bit more from your PowerPoint stuff. And if you really like this material, this is basically endocrinology. And it's a pretty good class, I think. Anyway, so embryology. So there's spermatogenesis. So during intrauterine life, the embryo is connected to what? Yolk sac that produces germ cells. Germ cells migrate to the primitive gonad. Oh yeah, sorry. Converted into what type A? Spermatogonia. That undergoes which type of cell division? Mitotic. This is a primary reason why a male, like a 100-year-old man, can still have a baby. Except the older you get, the more problems that can happen. But yeah. Cool. So after puberty, spermatogonia type A turn into what? Spermatogonia type B. Which participate in mitotic or meiotic cell division? Meiotic. It is then converted into a primary spermatocyte. Then to a what? Secondary spermatocyte. Then to a spermatid. Conversion of a spermatid to a mature sperm is called spermiogenesis. But the whole process is called what? What is this whole thing called? Spermatogenesis. This is one thing that really threw me off, so definitely know it. Know that just this step from spermatid to sperm is spermiogenesis, but this whole process is spermatogenesis. All right, so sperm, there's the head of the sperm, which has the acrosin, prostaglandin. What else? ACE, ACE. And how many chromosomes? 23. How many chromosomes does a dispermy sperm have? has 46. 46 plus 23 is 69. And that's what happens if, I think it's like if two sperms come together and they have two heads and they infiltrate the ovum, it gives you 69 chromosomes, which causes a problem with the baby. I think she usually says an abortion happens, like spontaneous abortion. But that's abnormal. That happens like never. So neck, mitochondria. What does the mitochondria do for the sperm? Increases energy, right? So it can keep going. What is the tail responsible for? Motility. Thank you. So it also contains calcium, zinc, and fructose to help with fertilization of the ovum by the sperm. So now we're at Sertoli cell. What do Sertoli cells secrete? Inhibin. Like the name implies, inhibin inhibits. So it gives negative feedback to what in the anterior pituitary? FSH. And what was FSH responsible for? What does fish? Sperm? Yeah. So spermatogenesis. So if there's a decrease in FSH, what happens to spermatogenesis? Decreases. So this is basically a feedback mechanism. You don't want to be making too much sperm. So if you're making too much, Sertoli cells secrete inhibin, and FSH is decreased, so then spermatogenesis is decreased. Does that make sense? Yeah? Okay. So now we have oogenesis. I always thought it should be pronounced oogenesis. So during intrauterine life, the wall of the yolk sac produces germ cells, XX, that migrate to the primitive gonad. Germ cells are converted into what? Oogonia. Oogonia. Oogonia enters into what cell division? It's actually meiotic. To be converted into primary oocytes and then stay dormant. So this is a primary reason why females have limited reproductive life, is because it enters into meiotic cell division when it's in utero, while males enter mitotic, so we have as many sperm as we need. Oh, it's under control, this is important, under control of oocyte maturate inhibitory hormone. This essentially stops the primary oocyte from being activated before puberty. So after puberty, during the menstrual cycle, so only one primary oocyte matures every month. The primary oocyte is converted into a secondary oocyte as a follicle develops and completes its first meiotic, awesome, division. Secondary oocyte completes the second, it's always meiotic for females, meiotic cell division once the sperm fertilizes the ovum. So if it finishes its meiotic division, it's fertilized. That's the only time it's going to finish its second meiotic division and turn into a mature ovum. Okay. So now we're at pregnancy. So release of enzymes from the head of the sperm dissolves the first two layers of the ovum. The corona, anyone remember? Radiata, awesome. And zona pellucida. It forms a what with 46 chromosomes? Zygote. Awesome. Once the ovum is fertilized, the corpus luteum begins secreting progesterone for preparation of the endometrium for implantation. Is everyone good? All right, we're at the last page. Oh boy. So if there's no fertilization, the corpus luteum turns into the corpus albicans. After the formation of the placenta, what is secreted? Which is the first sign of pregnancy? HCG. Human. Okay, I think I forgot actually. Chorionic gonadotropin. Yeah, that's it. So that's what the pregnancy test tests for. It tests for HCG. So during the I don't know why I have this here. During the second and third trimester, what takes over production of progesterone? The placenta. So this being in the stomach is called a what until week 8? Embryo. It's called a what after week 8? Fetus. And it's called a what after birth? Newborn. Awesome. So that's it. Before you go, please fill out that form that should be at everyone's desk. And thank you so much for coming. I hope you do well in the exam. And if you have any questions, now would be the time to ask them. Yeah. Yeah, there you go. They should all be in order.